We are about ready to go. Welcome to this forum. This is the College Research Seminar, and today our speaker is going to be introduced by Dr. Yoon.
Introduce?
Yeah, and the faculty in the Health Management and Policy Program, and they are co-sponsoring this particular presentation. So you'll introduce our speaker.
I'm very much honored to introduce Dr. Jon C. Dr. Collins is currently the Director of the Office of Health Analytics, Oregon Health Authority, and adjunct Assistant Professor in the Department of Psychiatry at OHSU. And he received his PhD a long time ago, right? In social psychology from the University of Georgia. And believe it or not, after a brief stint as a car salesman, it's not quite public health though.
No.
He began working in the healthcare research field and spent the majority of his 20-year career with the state of Oregon, making significant contribution to health for all Oregonians. And he has been publishing, presenting at national conferences, and bulk of his work is on the practical use of data within state government. So the presentation of today will focus on the use of data measurement to drive healthcare transformation in Oregon. So please join me in welcoming Dr. Collins.
Thank you, Dr. Yoon. So as Dr. Yoon noted in that introduction, I did spend some time as a car salesman, and I have to tell you, getting a PhD in social psychology is very helpful in selling cars. And it's surprising what you learn about people selling cars too. So as the title here says, I'm going to talk some about how we've used incentives at the Oregon Health Authority and working with our Medicaid managed care plans, or what I'll refer to quite often as CCOs, or coordinated care organizations. I put in here that how we've used incentives to improve population health, experience of care, per capita cost. I'll talk a little bit about population health, probably more towards the end, and I hope you guys remember to ask me questions about that, but I also put that in there as kind of a draw for you public health people. So, all right. So I want to get some basic things out of the way first. What is the Oregon Health Authority? I'm sure most of you guys have heard of the Oregon Health Authority, but what it is a big behemoth in terms of a bureaucratic organization. It's a conglomeration, basically, of our public health, our state public health department, which is very big in and of itself. And then also the programs that administer services for Medicaid, which I'll talk a little bit more about, and behavioral health services. And it also includes our Oregon State Hospital, of which there's the main campus is up in Salem, and the secondary campus is down in Junction City. So it's a really big organization. I think for the state, it's the second maybe largest organization in terms of budget and probably staff as well, behind education, several $1 billion every year in terms of its budget authority. The Oregon Health Plan is actually another name for our Medicaid program. The Oregon Health Plan itself has been around in Oregon since the mid-90s. I think it started in 94, 93 under Governor Kitzhafer's first term. And it's a very innovative way for a state to run its Medicaid program. There aren't any other states. What they say about Medicaid programs for a state is if you've seen one Medicaid program. So there's a lot of variation across the states in terms of how they end up running Medicaid. But Medicaid itself is a partnership between the state and the federal government to supply medical services to people who are in poverty or with disabilities and children. The Oregon Health Plan is kind of unique in the way that it administers services based off of a prioritized list. So we have something called the Health Evidence Review Committee, and that committee basically reviews a bunch of services and a bunch of different types of conditions and creates a list out of them based on, and the list is ordered in terms of how effective the services are for the different conditions. And they basically over the years have created a line that says all the services and conditions that are above that line can be utilized for the Oregon Health Plan, and those that are below can't. And the line used to shift to some extent depending on what the budgetary restrictions might be for the services or within the state. Under the waiver that we currently have with the federal government, which I'll talk about in a second, we had to basically draw the line and leave it there. Now, the health plan itself is also administered under what's called an 1115 waiver, which is basically a waiver for the state with the federal government to run the Medicaid program differently. The federal government has a bunch of rules around this is what the Medicaid program is, and this is how you should do it. Lots of states have basically asked for waivers to those rules. And in doing so, what they basically have to demonstrate to the feds is that they can run it better than the rules that the feds have given them. But by better, it usually means in terms of cheaper and with higher quality. So when you get a waiver from the feds, you have to basically demonstrate to them through an evaluation and other means that you are running the services better than you would if you just utilize the rules that the federal government gives us. The other big thing that we have in our current waiver with the feds, beyond just the prioritized list, is that you have to get a waiver in order to utilize managed care, which is one of the things that we do, and I'll talk about more. And you also, one of the key things, and what I'll spend the bulk of this conversation on, is we got a waiver to utilize incentive measures with our programs, with our managed care programs, in order to drive health system transformation. The coordinated care organization is basically a mechanism for us to deliver services. The state doesn't really deliver services itself, except in a few except part of the population of folks that are on Medicaid. For the most part, we contract with these coordinated care organizations. And what that exactly means is a lot of things, but the key point to remember is that under Medicaid, we cover physical health services, behavioral health services, which includes mental health and substance abuse services, then also oral health. Under previous conditions, prior to 2012, we had multiple types of managed care organizations. Some of them just covered mental health, some of them just covered physical health. These coordinated care organizations, which started up in 2012, basically are responsible for covering all of those services together. And the idea is that they would work to coordinate them to make them more efficient, deliver better services at lower cost. And the Medicaid expansion is probably the last thing just to be aware of, and you'll be able to see a really clear illustration of what happened under the Medicaid expansion. In 2014, under the Affordable Care Act, we were able to change the criteria that we had in place for allowing somebody onto Medicaid. Under normal circumstances, Medicaid is pretty restricted to a population of individuals with disability, children, and pregnant women. Oregon had already, under previous waivers and previous conditions, allowed for a slight expansion of that in terms of poverty. So people at certain poverty levels were allowed on. The Medicaid expansion allowed us to even expand further the number of people who are allowed on to Medicaid. And it really increased the population a lot, as you'll see in some of the graphs that I'll show later. It's hard probably for you guys to see this, but we had 16 different CCOs, and the green areas for each one of the CCOs is the coverage area that they were responsible for. Since the time that I made this slide, basically February of this year, we lost one of those CCOs, Family Care, which is over there on the left, second down, decided to no longer continue business, so we're left with only 15 CCOs. They vary quite a bit in terms of the number of members that they have within the CCO, and when I say member, that means that's a person that CCO is responsible for delivering all of its medical care for. But the largest of those is called Health Share, which is They're around 200,000 members, and actually now a little bit more. And they cover the Tri-County area up around Portland. The smallest of the CCOs is actually Priming County, which has just under 10,000 members. This graph right here is basically showing you an illustration of the impact of the expansion of Medicaid. Prior to the expansion, we had roughly 614,000 or so people on Medicaid, and it was dominated by children. They represented probably close to 60% of that population. Moved to 2016, we're covering a little bit over 1 million people, and that's still true at this point. It's right around 1 million. And the proportion of the population from adult to children made a switch, so that now roughly 60% of the population is adults. And as you can imagine, that's a really big deal in terms of shifting the responsibility that these CCOs had in terms of making sure that services are available for their population, going from a child-dominated population to an adult-dominated population. So I mentioned earlier in passing something called health system transformation. And putting these CCOs in place in 2012, and the particular waiver, most waivers last about 5 years. The particular waiver that we were under during that period of time, we basically put forward a vision for health system transformation with 3 basic tenets of better health, better care at lower cost. It makes for, it's kind of a big bumper sticker, but it makes for a nice selling point to the feds in terms of, that sounds good to us, please go forth and do that. And that's why they gave us the waiver that they did. But it came with a lot of hooks associated with it. So basically the commitments that we made to CMS, or the Centers for Medicare and Medicaid Services, that's our federal partner, is that we would end up reducing the annual increase of cost of care by 2 percentage points. Basically, on average, healthcare costs were increasing at about 5.4% year over year. We said we would keep it to 3.4. While we're doing that, we would ensure that the quality of care actually improves or certainly doesn't get worse. We developed an agreement with them, which they called the Quality and Access Test, that basically said that if we are demonstrating that we're keeping the costs down, that we would also have to demonstrate through a mathematical formula that the quality is remaining. And we were able to successfully do that so far. We have to ensure that population health improves. Now you'll note as I keep on going through here, and I made a joke at the very beginning, population health just to get you guys in here. And as I go through the slides, you'll see some things that are tangentially related to population health, but I don't touch on it a whole lot. Hopefully one of you guys will ask me a question towards the end, and I'll talk about it a little bit more, because it does still play an important role for us, although it's not something we've been able to address quite as much as we probably would like to. Establish a 1% withhold for timely and accurate reporting of data, which just means that when we send money out to the CCOs, if they don't get information back to us quickly, that we would hold money from them. And establish a quality pool. And the quality pool is what we'll end up talking quite a bit about. Our measurement strategy: an accurate measurement is worth 1,000 expert opinions. I don't know who Grace Hopper is, but I thought that was a great saying. So OHA's accountability to CMS, I went through those earlier points, but basically we came up with we agreed with CMS on a set of measures that we would track under the waiver. And there were 33 of those measures. And we had to basically demonstrate that in bulk across those 33 measures that we were improving things while lowering cost. And if we didn't at the time, there was also a financial bonus structure that the feds had given to the state. It was several billions of dollars. And if we weren't able to demonstrate that we were controlling cost and improving services, we had to give some of that money back to the feds. So there was a lot riding on that, because that money was being utilized to basically bolster and put in place a lot of infrastructure that had been missing from the healthcare system. That waiver was from 2012 to 2017. We're under a new waiver now that got put in place late last year, and we still have a set of measures that we have to track and report to them. The exact number, we're still negotiating on a couple little pieces of that. And we still have to demonstrate that everything's going great, but we don't have penalties because the federal government has changed quite a bit since the time that the waiver got put in place, and they're no longer funding us with any additional infrastructure associated with the system. But we're still on the hook for providing them with enough information to demonstrate that our waiver is doing what it's supposed to do. So CCO's accountability to OHA, and this is where the CCO incentive measures come into place. Basically, each year we go through a process to pick a set of incentive measures that's selected by a public group that's defined by statute here in state. It's called the Metrics and Scoring Committee. There's a couple folks here in the audience who have participated in that. The Metrics and Scoring Committee, 3 members that are basically research experts in the healthcare field, 3 people from the various CCOs that the state contracts with, and then 3 members at large, which means just people from the public in general who have some interest in healthcare. And what we've done over the course of the years is when we were setting up the CCOs, this group was brought together, and they picked out the initial set of measures that we would track to measure how well the CCOs were doing, and we used that information to set up a baseline. And then over the past several years, we basically have tracked the performance, looking for improvement over time for each of the CCOs. Quality pool structure. So when I say improvement, basically we give the CCOs some degree of latitude on that, because what we do is we set 2 goals for them, and if they achieve either one of those, then they're in a good spot. We set a benchmark, which is basically a high level of quality that we'd really like all the CCOs to achieve. But we also set an improvement target because we wanted to acknowledge the fact that in some cases the benchmark that we were setting for the CCOs was pretty high level, and it would, that's where we want to be, we also want to encourage the CCOs to work towards that. So we also gave them an improvement target. So if their performance at the end of the year on all the different measures that we had set up either met the improvement target or it was above the benchmark, then they were in a good spot. The quality pool itself, which is a pool of dollars, it'd be great if it was an actual pool that we could jump into and made them all gather it up at the end of the year, but we don't get to have that much fun at the state. But the quality pool itself represents a percentage of the dollars that we send out to the CCOs every year. It's varied over the years. We started off in 2013 at 2%. 2016 was 4.25%, and the 2017, which we'll actually be awarding to folks in a couple months, is also at 4.25%. I don't remember off the top of my head what the exact amount is going to be for 2017. We just recently calculated that, but it should be fairly close to what we did in 2016, and it represented $170 million split up amongst those 16, now 15 CCOs. So it's not an insignificant amount of money, even though it's that small a percentage. That just lets you know how much money is going out. The quality pool distribution has an interesting thing to it. It's sort of tied to how state government works. You're given a budget for a biennium, a 2-year period. If we don't spend all that money during that biennium, it just goes back. I don't know, it goes into the kicker or wherever it goes, but we can't keep it. So the quality pool itself, it has a 2-step process to it. We have the first part, which is basically, again, as I mentioned, we're looking for the CCOs to meet a benchmark or improvement target. We have usually from year to year, it's 17, 18, sometimes 16 measures, and the CCOs are required to meet at least 75% of those measures in terms of making their improvement target or benchmark. And if they do that, they get their whole 100% of their quality pool pie. So the pie itself is basically proportioned out based on the size of the CCOs. And if they meet 75% of their measures, they're going to get that full slice of pie. Not everybody does that, and so that means that there's some slices of pie left over for each of those CCOs. And rather than give that back, we created a challenge pool. And so what that means is that all that leftover money, after the initial amount of awards are made, we go back, the Metrics and Scoring Committee has picked 3 or 4 measures that they really wanted the CCOs to concentrate on. We go back and look and see, again, how the CCOs did for those particular measures. Then we divvy up the rest of the money depending on how well they did for those. That way we end up not having any leftover money to give back to the government, whatever would end up happening to it. So this kind of shows you basically for 2016 how those awards went. You can see up here that there's several of these CCOs in the green part of the bar that ended up getting 100% of their pie. And then they got additional money represented by the little orange piece, so that they ended up getting more than 100% of what they would have gotten. There are some CCOs like Cascade Health Alliance there, which is second from the top, that only ended up getting 70% of their pie. But because they performed well on a couple of the challenge pool items, they were able to get a little bit more. The awards themselves range from roughly, it looks like Willamette Valley was the community health, which covers the Salem area. They ended up getting around $22 million that particular year. The lowest award was related to, looks like Pacific Source Gorge, which is a very small CCO. So that wasn't, it was only around 2.2 million, but still that was a pretty significant amount. What the CCO's incentive awards, when they get them, is basically plow them back into the healthcare system. All of these guys are, not all of them, a good chunk of them are nonprofits. There's a couple of for-profits in here, but there are rules that are put into the contract that says that basically they're supposed to take this money in some way, contribute it back out into the community to help improve services. Because of some technicalities in terms of how we set up this funding pool for the incentives, we don't really have a very good tracking mechanism for understanding exactly how they end up spending the incentive dollars. That is something we're hoping to change, though, in the future. So the measure selection process. It's a public process. As I mentioned earlier, the people who are actually on the Metrics and Scoring Committee come from outside of the Oregon Health Authority. They're partially made up of people from the CCOs, but then they're also made up of experts in the field and just general community members. That's a nine-member committee, and basically every year they go through and look at the measures that we've had on the table for the CCOs, evaluate them, they look at all sorts of information, data, and so on, and make decisions about whether or not they want to continue with that measure or replace it. For the most part, the bulk of the measures have remained in place, but there have been some that they've dropped. And when they drop a measure, there's some pretty good reasons why that ends up happening. One of them is that the CCOs are all performing really well on them, so there's not a lot of improvement left to push on. We'll still track the measure, but we want to move into a different area and replace that so that we're pushing the CCOs along in something else that maybe they're not performing so well on. There have also been cases where some of the measures haven't really worked out as well as we thought that they would. We've actually dropped them. One of the cases of those is a measure called SBIRT, which is a screening for alcohol and drug services. When we started off using that measure, it was actually one that was homegrown here in Oregon. It wasn't a national measure, but we were able to put it in place, get agreement with everybody, and move forward with it. But over time, the codes that were used for that, which we rely on for a lot of our measures, changed, and the measure itself was no longer valid. So we took it off the list and started looking for other ways to track that. And we will end up putting it back on there eventually if the Metrics and Scoring Committee agrees to that. but it won't be measured the same way it was previously. The other thing that we have in place, and this isn't mandated by statute or anything, is the Metrics Technical Advisory Work Group, or Metrics TAG, we'll call them. And this is more of an ad hoc type group. Metrics and scoring has ultimate authority over the measures and the specifications that are used, but they're a bunch of busy people. They don't spend time kind of delving into the weeds of each of the measures. They move that off to the TAG group, the Metrics Advisory Group. And that group of folks actually kind of digs deep into some of the measures, and it makes recommendations back up to the metrics and scoring about the actual specifications we end up using. So this gives you some, I know it's a really busy slide, but this gives you some kind of idea about how the measures have gone over the years. So starting off in 2013, all the ones that have a little X in their row are what we were working with. And you can see that some of those have remained in place all the way through 2018, like adolescent well care visits. There are other measures that weren't in place in 2013 and have since been added, like childhood immunization status, which we work really closely with the state public health department on. Other things like cigarette smoking prevalence is another item that we added in 2016 that wasn't in place before. And then there are others that were only there for a short period of time. Early elective delivery, which is somebody basically going in for a scheduled delivery through a C-section to deliver. We had that in place early on and kept it for 2 years, but ultimately ended up dropping it because that was one of those where there was really good performance across the state on it. Our early elective delivery rate was extremely low. And part of that had to do with, one, it being an incentive measure and people working on it really hard, but also at the time the hospitals had all kind of grouped together and worked on this because it's considered poor practice to do that kind of thing, and they had already gotten pretty good at control on that particular issue. One of the new twists that we have for measure selection occurred when the legislature in their wisdom passed a new bill. It's referred to here as Senate Bill 440. I can't remember what the statute numbers are because there's like 9 or 10 numbers associated with it. I can't even remember my phone number. So anyway, they established what was called the Health Plan Quality Metrics Committee. And the idea behind this was good, and that over the course of this time, one of the things that's occurred nationally and within the state is a proliferation of metrics for healthcare providers, health plans, all sorts of levels of the healthcare system. And they felt, or the legislature felt, that it was getting out of hand, because what would end up happening, if you think about it from the point of view of a provider, that provider might contract for some Medicaid. So they might contract with a commercial insurer like MODA. And then they might have some Medicare clients as well. And each one of those different payer types had a different set of measures that they might feel are important, and they might put certain conditions on the provider or the health plan that's handling the services. So what the legislature wanted to do was try and create some consolidation of that. And they looked towards the things that they had the most control over, which are the CCOs. PEB and OEB, the Public Employees Benefit Board, and the Oregon Educator Benefit Board. I don't know if they cover Oregon State or not, do they? Yeah. So basically what they wanted to do was try and consolidate the types of measures that can be used as incentives and hopefully create a situation where the specifications for each of those are similar. PEB and OEB and the CCOs, since those are actually all within the health authority, I forgot to mention that earlier with PEB and OEB, that was pretty easy to do. The insurance exchange, which are the commercial providers, our healthcare plans that are on the exchange, we don't really have any authority over, but in terms of measuring performance, the idea was that we'd at least be picking the same measures for them as that were available for the CCOs and PEB and OEB plans. So so that's part of it. And then the other thing that did is that it created a situation where instead of the metrics and scoring having basically a full range of measures in which to choose from and basically pursue any direction that they wanted to go, it created a menu of measures. So they just recently actually completed the process of going through and picking out a set of measures, and they ended up with 51, which is still quite a few. But now the metrics and scoring is limited in what they can pick, and that they have to pick something from that 51 measures. It's a fairly it's a developing relationship, and I think over time they'll be working together because officially metrics and scoring is now a subcommittee of this other group. So I don't know that it'll end up causing any particular pains, but it's just an extra level of bureaucracy for the process. And one of the things that it also creates an interesting dilemma for, because in addition, as you may have noted in some of those measures that I showed earlier, they are moving towards more public health type measures, population health type measures with the smoking stuff and the immunizations. There's also a really strong need for us to do a much better job of incentivizing disparity type measures with the CCOs. And there's a number of reasons why that hasn't been as developed as it could be at this point in terms of putting incentives for a really wide array of CCOs that cover a lot of different populations and geographic areas. But this adds an extra layer into it in that the Health Plan Quality Metrics Committee would basically have to have signed off and put on their menu of measures anything that might be disparity related so that the Metrics and Scoring Committee could pick it. We'll see how all that ends up going. So moving on into the measured data sources, in God we trust and all others must bring data. Another good one for data people. There are basically three sources of data, if I'm remembering right off the top of my head. The biggest source is claims. So all these CCOs, we send out money to them, say deliver these services that are above the line in that prioritized list. We don't just give them the money and say good luck. We send them the money and we expect them to send back to us evidence of what they're doing. And most of that evidence comes to us in what's called a claim. Most all of you guys who are insured or know about this kind of thing because you get information in mailings after you go visit your doctor or whatever. But it's just a way that information is basically put into a set of data and sent back to the state to let us know that, you know, Joe Blow received XYZ service and it cost this amount of dollars for each one of those. We're actually able to do a lot of stuff with that besides just track the spending. A lot of the measures themselves have specifications in terms of how you take that information, combine it, which ones you use in order to track this or that happening. The data itself is collected on an ongoing basis, and what we end up doing with that information is we're able to feed it into some more automated processes and feed the information back to the CCOs on a regular basis so that any measures that are derived from claims, they can track their progress on that. And I'll show you some examples in a second. A couple of examples of actual measures that are claims-based are adolescent well-care visits, which is basically related to a set of procedure codes for adolescents. If those procedure codes come in, and we're able to count that as a positive. Emergency department utilization is another. Another big source of information for us is a survey. We use, mainly it's the Consumer Assessment of Health Plan surveys. This is a nationally standardized survey that we use. It's used all over the place, both for Medicaid and commercial providers. It has lots of benchmarks associated with it. So it allows us to compare performance with other places. Is that we actually get feedback from the actual clients, the members who are receiving services. So it's really important because otherwise we're just left with much smaller pools of data that might be related to complaints and or other kinds of personal interactions. And this allows us to collect stuff on an annual basis from a big set of folks. Another source is chart review. A lot of the measures that we track, you're not able to get exactly what you want from the claims information. And so instead, although you could rely just on claims, but to really kind of flesh it out, we allow for chart reviews. We refer to this as hybrid measures, but it includes both administrative data as well as medical record data. And what we do is we pull samples for each of the CCOs, send the information back for people who meet those criteria, and then the CCOs have people who are certified in chart review go and look for particular pieces of information in the charts. A couple of examples of those are colorectal cancer screenings and timeliness of prenatal care. You might wonder, well, why don't you see a screening since you end up paying for that in the claims? It's because it's a little bit more complicated than that. You have to be lots of times in order for somebody to qualify for the measure. We can look at, and we only see partial amounts of information in the claims data that's sent to us. But if you look in a person's medical record, there's a lot more information there, and it tells us whether or not this person truly qualifies for the measure and whether or not they might have actually had the screening. Another source, and this is a new and developing source for us, and one that we actually hope to be able to move towards, because a lot of the measures, because of how they're collected, are more process oriented rather than really being outcomes, which is what we ultimately want to see. And a lot of the information that could be more outcome oriented in terms of, you know, this person went through a treatment that was a success can be derived from electronic health records, or they're certainly in the handwritten charts that might still be available here and there out there, but that's really burdensome to collect. Electronic health records are at least pieces of information that are maintained electronically. The big problem is there aren't standards across the different types of electronic health records that are kept. If that were true, it would be a lot easier to collect information from them. But nevertheless, there are federal standards that are coming out that will improve that particular situation. But even with that not being in place now, we're still able to work with the CCOs and their providers and for them to pull information out of their health records, their electronic health records, into measures, basically the numerator and denominators. And one of the things that we track for that is where we're looking for poor control associated with HbA1c. That's a place where you need an actual figure to know that whether it's above or below the standards. And it doesn't come across in claims data, and nobody's going to end up listing it exactly right out in a survey that we might send out. But it is in the medical record and can be derived and packaged up and sent to the state so that we can track how well it's being done. So reporting. We go through all of this, and as I mentioned earlier, we actually, one of the reasons this has really been successful for us is because we don't wait till just at the end of the year, send out a set of reports to the CCOs and say, this is how you did, and award money based off of that. We send out information on a regular basis, and really for any kind of quality improvement activity to work well, and for you to have a relationship with somebody that you're paying to deliver these services, you need to have a very open and transparent process with them. So we developed a set of reports that we send out to them on a monthly basis. And what they're able to do, each of the CCOs is able to see how well they're performing on the particular metric, as long as it's derived from the claims. But further than that, they're able to actually click on to a particular measure and then go into and see the actual personal records associated with that individual. So they can, for example, look at the adolescent well care visit measure that I mentioned earlier. And they can see all the people that should be receiving a well care visit for all the adolescents. And they can see the list of people who haven't received those, and they can develop a targeted process to do outreach for that set of individuals and make sure that they receive that well care visit. And it's not just to check off the box and meet that metric. All of these different measures that we've been talking about are picked because they contribute to the population's overall well-being, the Medicaid populations, and they allow us to move forward with some of the goals that we have under healthcare system transformation. So even if they are just doing it to meet the metric, the fact that they're doing it is also actually improving the population's health. So in addition to the reports that we send out to the CCOs on a regular basis, we also make publicly available a few reports. There's a mid-year report that we put out which shows the progress for everyone, and then there's the final report which shows how everyone did for that particular payment year and how much money went to them and everything. This actually in in February, we put out a mid-year report for 2017, and we took a little bit different approach because in the past we've just been putting out information that says, here's how everyone's doing, but in this time we focused in on a few different measures and actually did a little bit of a deep dive of on our own to see what was really driving those measures or preventing some of the CCOs from performing as well as we'd like them to. The state has some levers in which to help them. We have a lot of technical assistance that we can offer from a clinical basis and a more technical side of things. But we do expect the CCOs to be diving into a lot of that information themselves so that they can continue to work and improve the services. So how are the CCOs doing? Well, this gives you some idea about, and we can't, I don't want to, this is not a research kind of experiment thing going on here. We have our incentive measures in place. We know that they concentrate somewhat on those incentives, but what exactly drives improvement on those incentives? Like I was just mentioning, we can dive in and see some correlational type information, but it really takes active work by the CCOs and their clinical staff working with the providers to make anything happen. And that's going to vary a lot across the state. But what we do know is that for the most part, the measures that we've attached incentives to have seen some pretty dramatic improvement. Adolescent well care, one of the ones that I've brought up quite a bit, the baseline for this was, it's hard to see there, but it was around 27% back in 2011. The last official measure of that for 2016 had increased all the way up to almost 43%. The benchmark for that is still quite a bit higher, so they have a ways to go. But just seeing this kind of improvement over the course of 5 years is pretty dramatic. This shows for that same measure how each one of the CCOs have done. The kind of light gray measure circle is basically 3 years ago. The lighter blue was a year prior, and the darker number showed, the darker circle basically shows again what their most recent performance was. In this particular measure, there was only one CCO there at the bottom that was showing some backward performance, but most of them were showing improvement. Another place where we've seen some pretty good improvement was for emergency department utilization. This is a really key measure for the CCOs because while on the surface it just tracks how often are you a member of the emergency department, that actually is related to and is a proxy for a much broader health of the healthcare system. Because presumably if people have access to services and they're receiving quality services out in the community, they don't need to go to the emergency department as often. And we started off in 2011 showing roughly 61 visits per 1,000 members. Again, we have about a million members, so you can kind of do some of the math. The next measure that we did in 2013, that had dropped pretty dramatically down to 50 emergency department visits per 1,000 member months. And it's continued to creep down a little bit. There was actually a little bit of a bounce back in 2016. And while there's a bounce back up, we're still not quite at that little dash line is basically the benchmark that we're trying to achieve. So we're not quite there. This was one of the measures that we spent a little bit of time on doing a deeper dive in that mid-year report that I just mentioned. And what we have kind of identified this as, a lot of the CCOs for some of the measures did have very dramatic improvement initially. But over time, as they kind of tackled some of the low-hanging fruit in terms of improving services, they have to work even harder to make those last little bits to get to that benchmark. And I think that's what we're seeing with the emergency department. Interestingly, the 2017 data, which we'll be publishing shortly, does show them making some improvement from 2016. So hopefully them seeing that they didn't get complacent in terms of their overall performance, and they kind of doubled down and worked even harder on it. And this again shows the variation across the CCOs in terms of emergency department utilization. In this case, lower is better. And you can see a lot of the arrows coming back towards the high numbers this last year, which is just illustrating what we saw for the overall statewide numbers. Assessments for children in DHS custody. This is a really interesting measure in that it's not something that you would typically see, or you would ever see, I should say, for a commercial health care plan. But for the Medicaid population, individuals who are on Medicaid are usually on a lot of different types of state services. They have all sorts of issues going on in their families that have contributed to either their situation in poverty, or maybe the disabilities that they have might contribute to their poverty. And there's all sorts of interaction between education, a lot of different social determinants and so on for this population. This assessment for children in DHS custody is a relatively simple measure on the surface, because what we're actually doing is we're looking to see that kids who go into custody, or in other words, by the state, because of what's going on in their family life or whatever, and the state's determined that their situation's not safe and they're placed in foster care homes or some other situation. What's supposed to happen by rule is that when that occurs, the child is supposed to go through a physical health assessment, an oral health assessment, and a behavioral health assessment. And those are all supposed to occur within a certain time frame. So basically what we set up here with this measure is a process for tracking that, to see that the kid received a visit to the dentist, a visit to a social worker, a visit to a primary care physician within 60 days. And if they receive all of those things, then the CCO would get credit. When we started out tracking this in 2014, and actually we were tracking this before, we made a change in 2014 and that we added oral health to that set of criteria, but it was down around 28%. The last time we measured it for 2016, it was all the way up to 74%. Which is great, but the bigger and more positive thing about this is that it really required that the CCOs work with their local Department of Human Services partners, their child welfare partners, and develop a coordinated system so that when a child went into foster care, was taken out of their home, the CCO was notified and they worked together with the child welfare case manager to get the child into the appropriate medical care so that they can receive the assessments that they needed. This is a huge deal and should have long-term benefits for the child, even if it, in some ways, it seems like a bit of a hassle for folks. But getting the kids that are in those situations in for assessments is extremely important, and identifying any potential issues that the kid might have. And identifying things early, as you guys know, public health is really important and has a really big, huge return of investment, not only in dollars, but just in health and quality of life. And these are some of the changes that have occurred for those CCOs. Now I'm running short on time, so I'm going to pop through a couple of these other ones. This relates to dental sealants, which we put in place and has seen some dramatic improvement, actually went above the benchmark. Again, the variation across the CCOs. Developmental screening, another one that has long-term benefits for kids who get into those services and receive the screenings that are necessary so that they can be referred off to appropriate services if that's appropriate. Effective contraceptive use. This one's somewhat stirred up a little bit of controversy, but on women's health and making sure that a woman's body is being appropriately cared for and avoiding unintended pregnancies. And it does have some controversy, as I mentioned. It's actually a measure that a lot of people have attached to and feel is very important. So improvement ahead. There's a lot of things that I just went over that are showing dramatic improvement, but not everything is. These two measures actually don't have incentives associated with them. And interestingly, we've mostly seen decreases in terms of the performance. So we have to, over time, and as we continue moving forward with the CCOs, think about how else we can improve services aside from just attaching dollars to those services. And we need to figure out ways to get the CCOs and the state, for that matter, to pay attention to some wider set of measures. And these two results here really illustrate the fact that that's needed. I threw this one in here. It's a little bit incongruous with the prior slides, but I did mention earlier that one of our main goals was controlling costs and not at the risk of quality. And I showed you a lot of different indicators that shows that we have improved quality of services over time. What this is basically showing you is how we've actually controlled the cost too. The little dotted line that's towards the top is basically what the projection of costs were going to be if the CCOs had not existed. The lower line in green shows what the cost ended up actually being. And the savings there in between is what the accumulated savings that have occurred over the course of the time that we've had the CCOs. It amounts to roughly a little bit over $2 billion. That's the kind of thing that makes politicians listen, perk up and listen, if they know that you're saving that kind of money in terms of taxpayer dollars and so on. So we've gotten a lot of attention, not only within the state, obviously, but federal, across the other states where people are visiting us, talking to us. We even had somebody from South Korea come talk to us yesterday. People are really interested in this particular model that we have going on with the CCOs, how we've balanced it out with incentive measures and other sorts of programs that we put in place to make sure the services are being delivered to who they need to be delivered to at a high quality, but controlling the cost. CCO 2.0 and Governor Brown's vision. So the first set of contracts with the CCOs were 5-year contracts, and they basically ran through, they're supposed to be 18. We added an additional year to the current set of contracts so that it runs through 2019. What we're preparing, though, is for a process to go out and open up bids for a new round of CCOs. And we anticipate that we'll probably have a lot of the same CCOs that we currently have out there, but there could be some changes that happen, some new players who kind of come into the system, or some of the current CCOs might decide to consolidate things for various reasons. What we're doing right now is setting up our request for proposals for those. And we're following a vision that Governor Brown has outlined for us and had passed on to the Oregon Health Policy Board. They're wanting us still to control cost. They're wanting us to increase value-based payments and pay for performance. All this stuff that I just talked about is the state's way of paying for performance, but from the state to the CCOs. But the thing that we're really wanting to push is how the CCOs end up paying their providers. A lot of the CCOs right now will pay their providers on a fee-for-service basis, which means that you do a service, we give you money. We want them to do things similar to what we're doing with the CCOs and passing on chunks of dollars to different providers and having them meet certain performance requirements or other kinds of criteria, so long as they deliver the services to the clients that they need. They have the idea is to create some flexibility in how they do that, so that they're not just simply focused on serving people, getting people in and out the door, but they're focused on the quality of the services that they're delivering. We need to focus more on social determinants of health and equity. This is the idea, and I think the example that gets tossed out there endlessly is the idea of buying the air conditioner for somebody who doesn't have one, and how that can ultimately contribute to the person's quality of life and their overall health. We want the CCOs investing more and more into those type of things. We've had some success with that so far, but not as much as we want. So we're looking for ways to double down on that in terms of increasing requirements in the contracts, and also tracking information, data that they might provide to us so that we can see how that actually relates to the outcomes. And finally, the final four things that she really wanted to push on us in terms of setting up the new set of contracts is to improve the behavioral health system. The coordinated care organizations are responsible for behavioral health, oral health, physical health. And the idea was for them to integrate those services as much as possible because we believe that it would not only produce better outcomes for folks, but it would also be more efficient rather than having them side on referrals from, say, one building to another. And those kinds of things are ultimately end up being barriers to healthcare services. Behavioral health services in and of itself is something that seems to the CCOs have had a hard time with in terms of looking for ways to integrate with physical health. And so we're looking for ways to incorporate in the contract ways to encourage for that type of activity to happen. It could be through incentives, it could be through other means, but one of the things that we're doing right now as a state is we're opening up a lot of dialogue publicly and doing tours around the state. We've had a couple of sessions, one in Portland, one in the Dalles. This weekend there's one in Woodburn. A couple weeks from now there'll be one in Medford, where we're collecting information from the public, people who are receiving services, providers, and so on, about how can we better address these things that I listed up here in the bullets in the next round of contracts. And then later on, after we consolidate some of those ideas, we'll actually be doing a tour around the state and hitting a lot more places besides just some key areas actually on this side of the Cascades, so that we can get even more feedback before we actually set up the RFPs. So that kind of brings me to the end. I think the slides will be available on some website here. I hope so. Looking around at somebody who might know. Yes, they will be. So there's some links here to give you a lot more detail behind some of the information that I provided. And it also includes contacts for getting in touch with me or some of my staff. If you do have questions about this is my email address. Valerie Stewart is the manager that I have who's in charge directly of the metrics program. Her email's here. And then we also have this email to the awesome metrics staff that we have within the Office of Health Analytics. It's just metrics.questions@stateor.us. And if you send a question to that, it'll end up getting answered as well. And that's it. And I know I'm close to the hour, but I'm certainly available if you do have any questions that you'd like to ask. Thanks. Any questions?
So, John, can you explain briefly how you came up with the projection, expenditure projection?
The expenditures projection? Okay, yeah, so the question was how we came up with what the expenditure projection was. And what we used and is available to us is basic data and history that in terms of how much money we'd been spending in the state on healthcare services, in particular for Medicaid services. We were able to track what the usual inflation was from year to year to year, and it was roughly around 5.4%. And so what we told the feds is that we would lower it by 2%, which was just kind of, it's not random, but there wasn't any particular logic behind 2% in particular, other than it would look pretty good and it would generate a lot of savings. And that's basically how those two sets of figures came about. One of them was based off of what history had been, and the other was based off of what we'd ideally wanted to be. And that's what we've been working towards.
If you're ever interested in doing microstimulation to do that, just let us know.
I will talk to our economist. Jeff, you first, and or go ahead then.
So when we look at the reports that you get from CCOs, there's a wide variation between the reports that come to you.
Mm-hmm.
How do you manage? So some CCOs seem to be concentrating on certain areas that the others don't. So how do you manage to produce an overall picture for this state when the reports are so diverse?
Yeah, so the question is basically how do we end up working towards an overall goal when we have a lot of variation amongst the CCOs? And that's a really important question for us now, because we spent a lot of time, really the past 4 or 5 years, setting up processes for just getting that information and producing it on a regular basis. And we've concentrated on, how, as I mentioned, the individual improvements going on for each one of the CCOs. So even if there is wide variation, as long as even the worst performing CCO is showing some improvement, we counted that as a positive. But we've taken a step back from that in terms of looking how that impacts overall state performance, which is what we end up having to report back to our state government and to our federal partners. And what we end up doing is, if we see CCOs that are performing particularly poorly, we examine their population and what some of their practices are, and we do targeted types of interventions with those CCOs. We have part of our organization within our bigger office, the Health Policy and Analytics Group. We have what's called the Transformation Center, and their whole mission within the Transformation Center is how we stayed up to the same level in terms of performance. So if there's some particular measure that all of them are doing poorly on, they will develop a process for doing training and working with the CCOs and their providers to bring up all the performance. They're seeing that the CCO that's covering Eastern Oregon is doing particularly poorly with adolescent well care visits. They will visit that CCO and kind of examine what's going on with the CCO and develop a strategy with them for improving performance. So that variation that we see relates to also differences. Even though they're all Medicaid individuals, there's a lot of variation within the Medicaid population, both in terms of demographics, race, ethnicity, and so on, and also the resources that are available to them for the health care. And seeing the variation across the state actually allows us to figure out strategies for how we can move and improve everyone, whether it's related to access to services or a particular provider type being available, or developing strategies that are associated with a particular cultural group that might be more prevalent in particular areas. Jeff?
I had to ask you, have you been able to demonstrate whether the CCOs have actually improved population health?
Well, what will be interesting to see, and as you know, because you sit on the Public Health Advisory Board, the Public Health Department in the state has looked at what we've done with the CCOs, and they've actually, while they're not developing incentives around them, they are looking at how at the idea of focusing in on a set of measures that they'd really like to see improve from a population health point of view, and setting goals associated with those measures. And they're starting to issue, I think they just issued their baseline report on that a couple days ago, actually. And they're going to end up working with the various county public health departments and other partners that impact those services to basically utilize a similar strategy to what we have with the CCOs, focus, targeted interventions, and so on to get performance. What we want to do with the CCOs and strengthen, even though it was in the contracts for this current period, but under this new set of contracts that I mentioned earlier, is really kind of beef that up in terms of the CCOs partnering with the local communities and the public health departments and the overall state public health to really look at their communities, because if the community is healthy, ultimately that ends up decreasing the cost of actual services. If the prevention activities are really good, it has a long-term impact on the health of individuals as they mature and become adults. We're looking for ways to better incorporate that. I think even though that was there through the first 5 years, almost 6 years now, a lot of what has been done a bit in the evaluation report that we had OHSU do for us. A lot of the time was spent around setting up the infrastructure that's needed to have this type of coordinated care. And now that a lot of that infrastructure has been set up and is available, we're really wanting to kind of push the envelope in terms of what people are responsible for and what we're ultimately trying to improve in terms of health in Oregon. As you can imagine, this is a bit of stretch for a healthcare organization who is typically focused on the health of the people that they're being paid to take care of. Some of the measures that we have make them kind of think a little bit more broadly about that, but it's still a stretch for them to kind of say, well, okay, so we're having, by whatever we're doing, we're having some impact that'll hopefully spread out to the more general population of the area. And it's going to be a work in progress, I would say.